Hello, everyone, and thanks for joining us today. My name is Marianne Gagnon, and I'm the Program and Events Director at Xavier Skin Foundation. I welcome you to today's webinar presentation, giving us a recap of all news related to non-melanoma skin cancer, melanoma, and ocular melanoma from the American Society of Clinical Oncology Congress held earlier this month. To give us this comprehensive overview, we are honored to welcome the highly esteemed Dr. Marcus Butler. I will hand the introduction to Kathy in a moment, but first a few logistics. All participants in the audience for today's webinar will be in listen-only mode for the duration of the session. If we have time, there will be a question and answer portion at the end of the presentation. To ask a question, please type it in the Q&A panel, which you can access at the bottom of your screen. Please feel free to ask your questions throughout the presentation, and we will do our best to answer them in the last segment. If there are any questions that do not get an immediate answer, we will contact you with a reply and any discussion you wish to have after the webinar. This session will be recorded and will be available for viewing in English and French on the Xavier Skin Foundation website and our YouTube channel. We will also send the recording to all who registered tomorrow. Pour ceux et celles qui voudraient entendre cette présentation en français, veuillez simplement cliquer sur l'icône Interprétation au bas de votre écran et sélectionnez le français. Par défaut, vous entendrez l'interprète à 80% du volume et l'audio d'origine à 20% du volume. Si vous souhaitez désactiver ou réactiver le son d'origine, vous pouvez cliquer sur l'option « Couper le son d'origine » ou « Mute Original Audio ». So thanks again for joining us. We will now begin the presentation. Here is Kathy Bernard, founder and president of Xavier Skin Foundation, who will now say a few words and introduce Dr. Butler.
Thanks, Marianne. Again, thank you to everyone for joining us today. My name is Kathy Bernard, and I am a stage 4 melanoma survivor and founder of the Xavier Skin Foundation. I would like to respectfully acknowledge that I am located on the traditional and unceded territory of the Syilx Okanagan Nation. It is my honor tonight to introduce Dr. Marcus Butler. Marcus Butler is a physician investigator with an interest in the translational development of immune-based therapies for cancer patients. He received his MD from Yale University in New Haven, Connecticut, and trained in internal medicines at Johns Hopkins Hospital, Baltimore, and hematology oncology at the Dana-Farber Cancer Institute in Boston. After serving on the Dana-Farber staff, he joined the Department of Medical Oncology and Hematology at the Princess Margaret Cancer Center in 2012 here in Canada. Dr. Butler is the Medical Oncology Disease Site Lead for Melanoma, Skin Oncology at Princess Margaret, and is Assistant Professor of Medicine at the University of Toronto. He is a Clinical Director for the Immune Monitoring Team at the Princess Margaret, where he focuses on immunologic impact of anti-cancer immunotherapies. Dr. Butler has been involved in the early development of several important immune-based therapies for cancer, including adoptive cell therapy and immunomodulators, including immune checkpoint blockade. He has a major interest in investigating the combination of standard and immune-based therapies as a method to address innate and emerging resistance to immuno-oncology. Dr. Butler has been a great resource and friend to Xavier Skin for many years, and we are so pleased that recently he's agreed to co-lead the Ocular Melanoma Physician Task Force of Canada. Without further ado, over to you, Dr. Butler.
Hi, thanks, Kathy, and thanks for the chance to talk with you all today. All right, I think you can see this proper part of the screen. Today, what I decided to do is select a couple of abstracts that I thought are important and lead you through the presentation so that you could get a sense of how to interpret this information. The meeting in Chicago that happens once a year, it used to happen at different parts of North America, but now it's gotten so big that there's only one conference center that can handle all of the activity. This meeting that happens once a year is a quite big meeting. There are many companies as well as physicians that converge on Chicago. 30,000 people meet and review the most recent data. The way new clinical trial data is presented is that basically after you do this big trial, it might have hundreds of patients on each arm of a trial. It's condensed into a 10-minute presentation that's or a small poster that describes all of the results. And then the presentation occurs and there's a discussant for the oral presentations. And then there's a lot of back and forth and discussion amongst the people at the conference as to how to interpret the data. So what that leaves people with is a very condensed, very highly technical description of the results. And I think it sometimes is a little bit difficult for the lay audience to really understand how to interpret this information. Is it important or not? And I think that what I'd like to do today is just show you a few of these presentations and lead you through what the doctors are really trying to say when they're presenting the data. Kathy, certainly if there's a comment that comes through, or if you have your own questions, feel free to stop me. I'm happy to pause during the presentation. So I have provided some consulting to these companies, and these are my disclosures. So how do you understand meeting presentations? Well, first of all, as I mentioned, these meetings are really a very important way of presenting new and recent data that gets disseminated out through the medical community. It's the most recent data, so updates on clinical trials that already have been presented will be presented in abstract form. And it may even be data that's important for practice, but isn't really enough data to show up in a manuscript. So the big companies and other folks that are wanting to try to get out information will send these presentations at a large meeting for exposure. So you'll have some companies will submit press releases, which basically say that there's a result that's important, but nobody's really looked at the data. So that's quite uncertain as to what it really means. These presentations, while very promising, haven't been peer reviewed. People haven't really carefully gone over the data to make sure that there's no mistakes. It has happened internally, but not externally. And so you have to take some of these results with a certain skepticism, because sometimes when we're looking at our own data, we look at it from one perspective that may have some unintended biases. But as I mentioned, it's a very short presentation. It's important data that then is discussed in the community. And ultimately, it does have a major impact on manuscripts that are subsequently presented. And also, the regulators are not necessarily looking at the data that's in the publications. They're looking at data that's been provided to the regulators directly. So that means that it gives us a sense of what the regulators are looking at when they provide approvals, because sometimes the regulators are getting the data before the presentations have happened. So, I think because these are such condensed presentations, I think it's a bit challenging for lay audiences to understand what's going on. So remember, first of all, that your oncologist is your guide. They'll help you to interpret any information that's coming out in press releases or in news reports. And then if you do end up looking at these charts and figures, it's good to ask an oncologist how to interpret it. So one of the lingo that we use in these presentations is that we use all these acronyms: RFS, DMFS, PFS, OS. What does all this mean? So the FSs, the RFS, DMFS and PFS are basically saying this is the amount of time that someone's alive without the first event. So relapse-free survival means the period of time that you're alive without a relapse. Distant metastasis-free survival means the amount of time you're alive without developing a metastasis that's distant or stage 4 from your presentation. Progression-free survival means progression, which means that there's growth or progressing of the tumor. Progression-free survival means that you're doing well without any evidence of the disease growing. And then overall survival is really our gold standard. It means whether the amount of time that people are alive or have passed away. So the statistics are really important basically what the statistics are helping us to do is that it's really trying to show that there's a very, very small chance that the results that you're seeing are not accidentally different for just a statistical chance. So if you take like 100 people and you give them and you do some intervention, occasionally you're going to get a surprising number of responses that's more than you would think would happen by chance. But occasionally this can happen. So the statistics will tell you that no, what you're really seeing isn't an accident, it's the truth. P-values, what the doctors are always looking for is a p-value less than 0.05. That means basically that you're 95% sure that the statement is true. And a hazard ratio is a number that's telling you how different two sets of curves are. So if you have a low number hazard ratio, that basically means that there's a small chance that two curves are the same. And it also is, it gives you a general sense of two sets of curves and gives you a sense of how different the curves are over time. So that if you have curves that separate early and stay far apart for a long period of time, you'll have a low hazard ratio. And that's what we're looking for in clinical trials. So, when you're looking at survival curves, the way to understand a survival curve is that 100% means that everybody's alive. And then as time goes on, patients might pass away. And then this curve drops. So if this is 90%, you'll see that 90% of people are alive at a very early time with this. This is basically before immunotherapy, standard of care in 2011. When people developed metastatic melanoma, they passed away pretty quickly in the first year. But then when we developed new drugs, patients were able to live longer. So the survival rate is higher for longer periods of time. And what you see in these two curves is there's something that we call crossover, where for a while, the targeted therapy works better for patients. But then after a while, targeted therapy works less well compared to immunotherapy, ipilimumab, nivolumab. And what the hazard ratio does is it looks at the shape of the curve and tells you whether these curves are different or not, and reducing it down to a number. Okay, so a very important study was presented, the Keynote 716 in Chicago. And this is a study looking at immunotherapy, pembrolizumab or Keytruda, given to patients who have stage 2B or 2C melanoma. And the reason why this is important is that currently we don't have a lot of treatments for stage 2B and 2C patients, and yet they're still at high risk of developing relapse. So in this clinical trial, a huge number of patients were treated on two arms. Almost 500 patients were given placebo, and almost 500 patients were treated with pembrolizumab after they were diagnosed with stage 2B. This means that it was a thick melanoma and that there was no lymph node involvement on the sentinel node biopsy. Patients were then followed. They were monitored for evidence of recurrence. And if the patients had a recurrence, they were unblinded so that you found out if they received placebo or pembrolizumab, and then had the opportunity to go on to more pembrolizumab at that time. Now, what's really important in terms of the statistics is that, as I mentioned before, the statistician look at the design of the trial, and then they decide what are going to be the primary endpoints and what are the secondary endpoints, and they define statistics to predefine a statistical analysis which will ensure that the data that's presented is true. The reason why this is important is that if you design a trial where you have like 30 different primary endpoints, statistically, there's a chance that one of the 30 endpoints will be positive by chance. And that basically is cheating, because if you just keep on doing the same thing over and over again, you might have something that's positive, but it's not really positive. And we really wouldn't want to treat patients based on that. So when people talk about a trial being clinically meaningful but not statistically significant, what happens is that sometimes there's a result, and that's the case for Keynote 716, for some of the results where you just don't, or maybe it's, sorry, I misspoke, it's on one of the other trials, where you're very close to statistical significance, but it's not demonstrated. And the statisticians don't let you run statistics later, because if you keep on checking, then there's a chance that you'll get a false positive. So they're preventing that from happening. Okay, so previously for the Keynote 716 trial, there was data presented at other meetings that showed that patients who received pembrolizumab had fewer relapses. That means that more people are alive for longer with no evidence of relapse compared to the patients who received placebo. And if you look at these two curves, you can see that the second set of curves look very similar, but maybe there's a little bit extra space between them. The reason why that's happened is that in the interim analysis 1, patients were analyzed, and then interim analysis 2 was a little bit later. You can see here that's 15 months, but now 15 months is later. It goes up to 27 after 33 months. So basically, with longer follow-up, we're seeing more separation in these curves. So usually when we have these presentations, there'll be some explanation for the analysis and statistics that are being conducted. And then they'll describe the clinical trial, which is this nearly 500 patients receiving treatment or placebo. Whenever you see these types of trials, they'll talk about baseline characteristics, and then the presenter will describe the characteristics. What the doctors are really looking at is to see whether there's an imbalance that could explain the difference. So stage 2C, for instance, is worse in terms of prognosis than stage 2B. Patients with stage 2C do worse. So if there were like 50% of the patients were stage 2C, but only 30%, sorry, stage 2C who got placebo, but only 30% got pembrolizumab, there would be there might be a difference in survival, but it might be because of a baseline characteristic. So what the doctors will always say is each arm was well balanced for a good trial, or they'll point out a difference that might explain some of the differences seen later. So there's this concept of distant metastasis-free survival. What that means for an adjuvant study is that if you have a relapse locally, that is a relapse. So the relapse-free survival goes down. But if distant metastasis means a relapse that occurs anywhere in the body but not locally. So if you have a distant relapse, that we think is a surrogate for overall benefit and possibly for overall survival. So the doctors are very interested in distant metastasis-free survival as a important element. And what this trial did show is that there is a difference in distant metastasis-free survival. There is a p-value less than 0.05, so check, that looks like it's significant. And the hazard ratio is 0.64. What that means is that 36% of patients did better, or there was an effect of, when you look at the overall curve, it's 36% better compared to the placebo arm. And what people are really looking at in terms of hazard ratios is whether this range, which is a statistical analysis about how sure you believe that the hazard ratio is 0.64, what doctors are looking for is whether it crosses 1. Basically, 1 means not statistically significant. And this result of 0.64, where there's not a crossover to 1, means that it's we're pretty sure that these are definitely different curves, and that patients who receive pembrolizumab will have fewer distant mets, suggesting that they might do better in the long term. Now, the other thing that you should look at here is that we're out at 3 years, and that a lot of the patients are not having any evidence of distant mets, even though they just got placebos. Their surgery alone seems to be working for these people that are out of this area. And that means that about 30% of patients have relapsed, but 70% haven't. And you can improve or reduce the amount of relapse a bit, as you can see here. And with further time, we're hoping to see further separation of the curves, showing that it's worth receiving the treatment. But what's most important to remember is that many patients still don't relapse even if they receive placebo, and therefore they didn't need the therapy. That's one of the challenges with adjuvant treatments. So then what happens after you show that kind of result is you look at subgroups. Here they looked at different T stages, that's the thickness of the tumor in the skin, and you show that the curves are different for all 3 of these T stages. What this analysis also did is they looked at where the distant mets occurred, and we saw that most of the mets that were being prevented by pembrolizumab were occurring in the lung. This is an early look, and many of us think that with time you'll see other organs showing less relapse. But it's just because it's such an early time point that we're only seeing it in the lung, which is a little bit easier to pick up lesions because of high resolution CTs looking at the lung tissue. Then there's this sort of plot that is looking at different categories and seeing which of the categories is favored by receiving pembrolizumab compared to placebo. What doctors are basically looking for is areas that don't cross the midline, number 1, and to see whether, if it doesn't cross the red line, how different or how much it's favoring one treatment over another. And basically the conclusion when we look at this is that all of the different categories seem to benefit, and that when you see these low numbers, it's probably, when you see crossover the line 1, that's probably because they're just low numbers of people in that group. So distant mets is different than local, than relapse-free survival, because relapse-free survival includes distant and local relapse. And what in the presentation, when they showed this, they're basically saying, hey, look, the relapse-free survival is still different. And if you look at the shape of the curve, it continues to be different, and you kind of see additional separation of these results. And they'll give the hazard ratio, and you're looking to see that the curves continue to have a hazard ratio where you don't see crossover of this 1. And then they did a subgroup analysis looking at the relapse-free survival, and then assess the patterns of where people are recurring. Basically, the bottom line is that we're seeing fewer relapses with pembrolizumab in the distant sites. We're seeing similar amount of local regional relapse. One of the unknowns is whether patients who stop therapy and or who develop a recurrence while on treatment, whether they should continue on adjuvant therapy or stop. This trial doesn't answer it because patients had to stop treatment if they were on therapy and developed a relapse. But some medical oncologists think it just remove the lesion that relapsed and continue the patient on treatment. So then the typical story for these types of presentations is that you look at side effects. So basically what they did in this presentation is they look, we have fewer relapses, there are less relapses in the lung, and these are the side effects. This is the cost of the therapy. You know, the bias when you're presenting this type of data is that, oh, the toxicity isn't that bad. You can tolerate it, but you know, you need to look at this with a careful eye, and you can see that a number of patients developed hypothyroidism, which tends to be a permanent condition, so that patients are going to have to continue on thyroid pills long term. What's really interesting and important for this therapy is that we believe that we can reduce relapses. There is a cost in terms of side effects, and as I mentioned, many patients probably with this stage of disease may never have relapse ever because they can be cured surgically, but we can't figure out who those people are. So then at the end of a presentation, there's a summary of the events, of the conclusions that we mentioned. And there was also quality of life data that basically showed that the treatment was reasonably well tolerated by patients. So the take home here is that stage 2 disease can be treated with immunotherapy to repeat recurrence. Most people don't really need treatment because they are cured surgically, but we can't figure out who those people are. So we have to treat everyone. When you do analysis of the numbers, about, I believe it's around 18 patients have to be treated in order to benefit one patient. But this is in line with the benefit that we see with treatment of breast cancer to prevent breast cancer recurrence. More time is needed for this trial to mature. It's a very early time point, and we will hopefully see that we have continued spreading of the curves with time. Now, one of the issues is that overall survival may never be shown because patients do have access to other therapies after treatment. And the question then is whether going on to an adjuvant therapy is worth it. I think that's an important question to have a discussion with your oncologist when and if this becomes available, and we believe it probably will very soon, because you have to basically look at lifestyle, impact on lifestyle, and your activities over the course of the year, possibility of long-term side effects that might occur. So some patients may say, I'd like to enjoy my life now. I've had my surgery and just be monitored. And then other patients would prefer to be proactive. One of the challenges we do know is that there are situations where patients will have a relapse and their disease is quite advanced, and we wonder if we had been able to treat those patients earlier, maybe they would have done better. So hopefully in the future we'll have better biomarkers so that we can identify patients at higher relapse. Now, another very important abstract that was presented Kathy, are there any, Kathy, you can feel free to stop me if there are any questions that you want to throw in.
No, we're good. We're good to go.
Okay, sounds good. So another important study was the Relativity 047 study. So this was a clinical trial looking at a doublet immunotherapy of nivolumab plus relatlimab compared to nivolumab. So nivolumab is the drug Opdivo, and relatlimab is I think it actually, I can't remember what its brand name is, but when you put the two drugs together, it's Opdualag. So they're basically marketing this doublet as a single type of therapy. So what is of great interest is that the combination 047 in phase 1 showed some activity, and it's looking like it's showing activity in the first line setting, and it looks less toxic than the ipilimumab plus nivolumab study. So ipi plus nivolumab is a combination therapy that's used as standard of care. It's effective at treating melanoma, but it has a lot of toxicity. We use it, but it's quite challenging. Nowadays, we have 6.5 years of follow-up, very mature data from 067. And it's really become ipi plus nivolumab as part of standard of care. But there's a hope that nivo-rela can give us the same effect, but be less toxic. So this clinical trial looking at this combo was compared to nivolumab alone. Now you notice there's a kind of a bait and switch here. I'm talking about how this combo we hope will be better than ipi-nivo, but they actually compared it to just nivolumab monotherapy, which many of the clinical trials do. And it forces the doctors who are considering both combinations to have to draw comparisons across different trials, which is not straightforward, and it's a little bit complicated, inherently biased, but it's the best we can do. And this trial looked at progression-free survival. So these patients have stage 4. You're waiting to see whether the patients who have responses or have stable disease have further progression. And then there's overall survival and response rates for secondary endpoints. So like I mentioned before, there's this baseline characteristics, and whenever you see a difference, there will be a highlighting of the difference by the presenter. And you can see here that they've highlighted the fact that 42% of the patients with nivo-rela had M1C. So M1C is a more aggressive form of stage 4 melanoma compared to single agent. So there are 42% versus 35. So you would expect that to mean that patients with nivo-rela would do worse than nivo alone. And then there's also pointing out of patients who had atypical diagnoses. So the skin cutaneous melanoma is the garden variety melanoma that has a higher response rates with immunotherapy. Acral melanoma and mucosal melanoma have a bit lower response rates, and those were included in this trial. Unfortunately, for our uveal melanoma patients, they were excluded, which is quite typical of a lot of the large melanoma studies, because the uveal melanoma patients behave so much differently than the other groups. And then they also looked at various molecular markers and stage to make sure that there was balance on the two arms. So here are the slides which show difference in overall survival and progression, progression-free survival. Now, previously, PFS or progression-free survival was presented, and it showed a difference. This continues with this later review. So we do believe that you have less progression episodes when you receive the combo compared to single agent. Now, overall survival shows a difference. You can see the shape of the curve is different, but the statistician will tell you, yes, it looks different, but there's a chance that this difference is just an occurrence by chance. And the way you can see that that's what the statistician is saying is that when you look at the hazard ratio, it's a low number, that's great, but it crosses 1, so 1.01, so it just misses being statistically significantly different. And also the p-value was greater than 0.05. And again, it just misses being statistically significant. And as you may have heard me mention earlier, the statistician set up rules at the beginning of the trial and say, okay, we're going to look at overall survival at this date. And if it's statistically significant, then you're done. If it's not, then it misses that endpoint. And you're not allowed to look at it again. So the trial figures could continue to widen so that everyone believes that there's a statistical difference, but because of the way the trial was set up, you will never get a p-value again. This is the last chance, and it's not statistically significant. What happens, however, is that patients and doctors look at these differences, we see it over time and what happens. And even though the statistician says that we can't say it's statistically different, it does impact regulator decisions, and it impacts our decision-making process. So they then did this subgroup analysis that looked at different groups, and that essentially there isn't really a clear biomarker to help guide us on who should get the Rela-Nivo combination. It was interesting that we saw a difference in the acral and the cutaneous melanoma that looks promising. Mucosal may not, and there is a fair amount of data that says that ipi-nivo is better, combo is better for mucosal. So the way the doctors are looking at this is that, okay, we know that mucosal does really well with ipi-nivo. I'm not going to switch them to Rela Nivo based on this subgroup analysis. The other thing that's important is that the patients who are older still seem to benefit from the combination. So for patients who you may want to avoid the toxicity of ipi-nivo, the Rela-Nivo may be a good compromise. The other thing that's interesting is that for unclear reasons, patients with BRAF wild type melanoma had less of a difference in the ipi-nivo studies, the 067 studies. But you see that the wild type melanoma patients are doing well, suggesting that maybe we shouldn't be afraid to switch those patients over to Rela-Nivo rather than ipi-nivo, although that's completely unclear. We need additional randomized data to make that decision. And then there was also analysis that even patients with high tumor burden seem to benefit, and that there really wasn't any particular subgroup where you would give single agent anti-PD-1 over Rela-Nivo treatment. So then they look at several different curves, looking at LDH and BRAF mutation status, again, showing in graphic format differences in the curves. And we're basically looking at these things and seeing if we have a gestalt that there's a difference. As you can see, these curves are different, but also it's important to share with patients what this means. It means that at a year, if you're on the Rela-Nivo, you have a 50-50 chance of having your disease not progress. But if you receive anti-PD-1 alone in this study at a year, 38% of patients haven't progressed. So a lot lower number of patients have not progressed. What's also interesting in these, when we look at these curves, is that in this particular study, the patients who receive Nivo are doing a lot worse than in other earlier studies. And that's probably has something to do with the type of patients that end up going on to these trials. These patients were decided not to go forward with Ipi-Nivo combo, which in many of the jurisdictions where the trials were taking place was an option. So therefore, it may skew the type of patients who are participating in the study and have an impact on how the study behaves. And then you look at safety. What's most relevant in terms of the safety is that the rate of toxicity, treatment-related adverse events, as opposed to any adverse event. Treatment-related adverse event is only 20% compared to 10% with patients who had single-agent Nivo. And our experience with combination Ipi-Nivo is that at least 55 to 65% of patients will have a grade 3 or 4 toxicity, no matter what you do. So it looks like Nivo-Rela is safer, fewer side effects compared to what we see with other combination. And certainly it's reasonable in the ballpark of single agent. And then they'll describe what the toxicities are and any major event that's of significant difference. Overall, basically what this is showing is that the types of toxicities are common, what we see with immune checkpoint inhibitors, and that there's nothing surprising. So the presenters basically are saying that the primary endpoint, which was relapse-free survival, progression-free survival, was met, and that the change was consistent with longer follow-up. The overall survival and response rates were described, and there are differences, but the statistical analysis for overall survival wasn't statistically different. However, many doctors are thinking this is clinically relevant. So basically, the point of the abstract is that it's manageable and safe, and many folks in different areas are thinking that Nivo-Rela is the way to go as opposed to single agent anti-PD-1. But the real question is whether there's a difference compared to the combination Ipi-Nivo. I think many of our patients would be very happy to have a highly effective combination therapy that isn't as toxic. What I've done here is I've thrown up a copy of the slide from the current presentation, looking at overall survival for Rela-Nivo. And if you look at this, you'll say that, well, you can easily see there's a difference in the two curves. If you go back to what things look like at the first time point for the ipi-nivo study, the first presentation showed this graph looking at overall survival. Now, the green is ipilimumab alone versus combo in the orange versus the blue, which is a single agent anti-PD-1. And what we have always noticed in this trial is that basically the combo was identical for the first year. With more time, the curves are splitting, and actually in the long-term data, the difference continues to widen over time. But what's interesting is that ipi-nivo, the differences were less impressive than the Rela-nivo versus nivo study. This is interesting. It's hard to know what to make of it because this is different clinical trials, but it does make some doctors encouraged that the Rela-nivo is really a step forward in terms of therapy. So the take home is that this appears to improve progression-free survival, has a better response rate over monotherapy, and it certainly may be a good option for patients who would otherwise receive monotherapy. They're not interested in the toxicity of combination ipi-nivo. But we're really not sure which is better for patients, ipi-nivo or Rela-nivo. And further analysis and studies will hopefully answer that question in the future. And really, there is a major unmet need for biomarkers to help us guide therapy. So this is halfway. I'm going to go through two more abstracts. And Kathy, feel free to stop me if there are any questions. But we're going to shift gear here and talk about Merkel cell study. So this is an exciting type of so there's a question about how many doses Rela-nivo were administered in the prior presentation. They actually give the doublet once a month. So it's basically continued as a doublet as opposed to the ipi-nivo where you give 3 doses and then you switch to nivo maintenance. So there's this new drug that was presented. It's called KRT-238 or navtemadilin, which is an interesting new drug that's showing activity in Merkel cell carcinoma. So this this study had an oral presentation. This is the type of study that what we really think of is as up and coming or very exciting, very fresh off the press, new data. The first 2 studies that I presented to you were large randomized phase 3 studies. This essentially is an early phase study looking at the development of a new drug in a particular patient population. In this case, looking at patients with Merkel cell carcinoma. So Merkel cell carcinoma is a type of cancer that develops in the skin. It has a neuroendocrine differentiation, and it's a really tough type of skin cancer because it grows fast, aggressively, and can develop resistance to therapy very quickly. So Merkel cell is highly mutated. It can be treated with chemotherapy, but often occurs in older patients who do not tolerate chemotherapy. And chemotherapy only works for a limited amount of time. Unfortunately, patients will have progression after treatment with chemotherapy. And then it turns out that Merkel cell is highly responsive to, to immunotherapy, resulting in good clinical responses in patients. But unfortunately, a fair number of patients have resistance and need additional options for therapy. So Merkel cell carcinoma is initiated in many patients with a virus called the polyoma virus. It is present in about 80% of Merkel cells in North America. In other parts of the world, like Australia, there's less polyoma virus and more ultraviolet radiation-related Merkel cell. The polyoma virus encodes for some molecules that modulate a molecule called MDM2. And what happens is essentially the p53 function is suppressed so that tumor cells grow. So basically, the bottom line is that this drug inhibits MDM2, and by doing that, you can inhibit the growth of Merkel cell carcinoma by allowing p53, which is important in initiating death of cells. It allows the p53 to function properly. So in this case, this drug is only available or would be calculated to work in patients who have normal p53, which is in a good percentage of patients with Merkel cell carcinoma. When they present these new types of drugs, then there'll be some information about the new drug and how it works, and that's what this cartoon and description does. And then they'll show some preclinical data that provides a rationale for why this drug would be helpful in Merkel cell. And essentially, KPT 232 can kill Merkel cell lines in culture, and that was the rationale for moving forward with the clinical trial. So in the clinical trial, several regimens were used to assess tolerability and safety. What happens when you're looking at multiple regimens is that you present the overall results, but you're really not sure what the best results will be because you haven't really treated that many patients with the optimal regimen that's tolerated. Again, baseline characteristics are described where you look at the different regimens and how many patients were treated. And as you can see here, we're really talking about low numbers, 6 patients on this regimen, 7 on this one, 10 on these arms. So in order to analyze the data for presentation, a lot of the curves are looking at the overall response, but they got the same drug, they just got the drugs in different ways. So it's very promising, but additional patients need to be analyzed to understand the benefit of the treatment. So with this new drug, there's a fair amount of nausea and vomiting, diarrhea, and that's described here, and different strategies for dealing with the toxicity. And then they shift into what we call waterfall plots. So a waterfall plot is where individual patients are lined up and where you can see how much shrinkage or growth of the tumors occur on the CT scans. And what you see here on the far right is that patients in this arm, one patient had a really good PR where there was a significant shrinkage of tumor. There's a good PR in this arm of 70%, fair amount of stable disease, which is defined as at least 30% decrease or 20% increase, and then greater than 20% is progression of disease. And then the analysis looks at putting all of this information together in a waterfall plot where you can see patients lined up and you can look at the overall benefit. And what they did here is they looked at patients who received no chemotherapy and saw very promising results, whereas patients who had prior chemotherapy as well as immunotherapy, the results are a little bit less encouraging, suggesting that you should use this new drug before you give patients chemo. So waterfall plots tell you shrinkage, but if there's shrinkage that lasts 2 minutes, it's not really that helpful. So the next set of slides are called swimmer's plots, where you can see patients who, again, individual patients are shown, and you can see how long the responses last. You always have to look over here on what the little triangles and other things mean. We have some patients who remain on treatment even if there's progression and then you stop, which is what is represented in these slides. Or sorry, in this slide. And then there's a picture of in terms of what is seen in terms of durability and some graphic images in terms of responses to therapy, as well as radiographic responses. So what happens with these early phase studies where there's a limited number of patients that are seen or participating in the study is that you have a little bit of extra time so that you can show examples of benefit in patients. So in summary, this new drug is a targeted therapy that seems to work in patients with Merkel cell carcinoma. It's quite early, but it seems to work in patients who have failed anti-PD-1 or PD-L1 therapy like avelumab, and it seems to work better in patients who've had no prior exposure to chemotherapy. And there's plans to look at patients who failed immunotherapy as a treatment later this year. And there are some centers in Canada that are investigating this drug, hopefully soon at Princess Margaret. Currently, there is a cohort of patients who are treatment naive in terms of immunotherapy or chemotherapy, and they're accruing patients to that arm.
Dr. Butler, I have one quick question from a patient about the Relativity. I'll translate it really quickly for you. I had 4 doses of Ipi, and then I followed up with Nivo. I had a reoccurrence 8 months later. Should I understand that I would have had better chances with the Relativity?
Yeah, so no, we don't. I don't think we have data that really tells us that yet. First of all, we don't have any randomized data comparing those 2 regimens. So it's very, very difficult to really make a lot of it's very difficult to say something clear about ipi-nivo versus rela-nivo. And I think we're really going to need additional studies to be able to know for sure. The data is way too immature to be able to even take a clear guess on that. One of the issues with the rela-nivo is that we don't have long-term data. So the curves might be separated now, but in 2 years, we may look at the curves again, and they come right back together again. And if that's the case, then patients should stay on ipi-nivo, and we won't be able to go on to other doublet therapy.
Thanks.
So for this new drug with Merkel cell, it's very promising. It's a very early study, but it's showing a benefit, and it looks as though the response rates are encouraging. And as you saw, there was graphic benefit in some patients, and that if you develop Merkel cell, it's definitely worthwhile looking at options before delving into therapy because of the these development of new drug options. It's still very early, so you have to be on a clinical trial, and as I mentioned, there are some restrictions on exactly which types of patients will go on the trials. So it's good to make a connection with the cancer center early before initiating new therapies. So uveal melanoma, we have a few things. There's been a lot of action in uveal melanoma in the last few meetings. So this year it was a little less active, but I think it's useful to touch on some of the data that was presented at a poster discussion that looked at liver-directed therapy, because I'm sure patients with uveal melanoma will have questions about that. So uveal melanoma is a type of rare melanoma that starts in the eye. And for the recent years, immunotherapy with immune checkpoint inhibitors has been the treatment of choice for these patients. Some centers like our own will use liver-directed therapy as an option. In the last couple of these big meetings, there has been exciting results with a new drug called tebentafusp. Brand name is Kimtrac, just got approval by Health Canada, and it improves survival in patients that receive the treatment, but only half of patients are eligible for tebentafusp. So what are the options, and what are the other options for patients? So one of the questions is immune checkpoint inhibitors. So for patients that receive single agent anti-PD-1 therapy, if you have skin melanoma, you have a pretty high response rate. And ipi-nivo gives a little bit higher benefit, but there's really only about 8 to 10% difference between the two curves. And in other words, at 5 years, instead of 49 or 45% of patients alive, you'll have 53% patients alive. So there's a small improvement with ipi-nivo with skin melanoma. And there's never been a randomized study looking at uveal melanoma, but there have been large meta-analyses. That's where you put a bunch of trial data together and reports together to get a general sense. And it looks like nivolumab or pembrolizumab alone gives a response rate of 5%. That's 1 in 20 patients will have shrinkage of their tumor. Combination therapy has been investigated by a group at MD Anderson as well as a group in Spain. And the response there is a rate is around 15 to 20%. So that's definitely better than single agent. But the combo is toxic. It causes a lot of side effects. Same number of side effects that you see with other melanomas, just not as good of a response rate. So there really is a question that we have on whether or not toxicity is worth it. So, one of the questions is in the real world and looking at other reports, what is the response rate and the survival rate for patients receiving combination immunotherapy. There was a group at the University of Iowa that looked at 8 different studies that have looked at combination ipi-nivo in uveal melanoma. And when they looked at all of the information together, they see that the response rate is about 13.7%. So it's in the ballpark of what the Spanish group showed in terms of a response rate. Overall survival is a difficult one. It's a difficult number to really know how to interpret because it really depends on when patients are receiving these therapies and whether they're identified early through surveillance or later. But it is quite concerning that despite the response rate of 15%, patients are living about a year as opposed to much longer, which is what we really would hope. With the tebentafusp study, it looks like patients do live longer with that therapy. So patients are receiving tebentafusp in my clinic as first line. Some groups are unsure because there hasn't been a comparison between ipi-nivo and tebentafusp head to head, so that some groups treating uveal melanoma may prefer ipi-nivo. But in any case, it's an area of controversy. Both treatments have lower response rates. But what's interesting about tebentafusp is that even if the response rate is low, if you continue to treat patients despite progression of disease, they'll do better. And in one of the posters that was presented this year at the ASCO meeting, they showed that if you continue to treat beyond radiologic progression, survival was improved compared to the patients who did not have additional treatment. Now, there was a poster discussion looking at 3 different trials that look at a new type of therapy called isolated hepatic perfusion, IHP. And I think it's useful to at least review some of this so that people understand the status of intrahepatic perfusion, because it's a quite involved process, and it is a treatment that's promising but still in the research realm. So uveal melanoma is a disease that starts in the eye, but 90% of the time, at the time of relapse, the liver is involved. And half of those patients will have liver-only disease. If patients have a small metastasis, in addition to the systemic therapies that we talked about before, you might do surgery or intervention called radiofrequency ablation, where you zap the tumor and keep it in control. However, patients can develop progression where there's too many lesions to treat with a local approach. And what some investigators and clinicians have done is administered drug directly to the liver. There are several different types of treatment that address this. One of the treatments is intrahepatic perfusion. Another treatment is TACE or Y90. So here is a liver that you see here at the time of surgery, and there are multiple little black spots on the liver, which are consistent with the liver metastasis. And liver-directed therapy that is mentioned down here. TACE stands for transarterial chemotherapy embolization. So that's where chemo is administered by interventional radiologists and then is deposited in the liver. And Y90 is when radioactive beads are administered. Intrahepatic perfusion is a surgical procedure where a patient has a laparotomy. That's a surgery where the abdomen is opened up and a device is placed into the vessel that feeds the liver. Chemotherapy is perfused into the liver, and then the device basically suctions out the chemotherapy so the rest of the body is not exposed. Percutaneous hepatic perfusion is basically the same idea, except you don't require a surgical procedure. It can be done with catheters that are basically you go through the blood vessels and then perfuse the liver with chemotherapy, and then remove the chemotherapy so that the body is not exposed. And then we mentioned TACE, or transarterial chemoembolization, and Y90, where radioactive beads are administered. So in one of the studies done by the Scandinavians, they did this intrahepatic perfusion study, isolated hepatic perfusion study, where 40 patients received this treatment, and the other 40%, 46 patients received best alternative care. Most of the patients had chemotherapy, a couple of patients had ablative therapy, and immunotherapy was given in about 47% of patients. This is an older study, so fewer patients got combo. And what they saw is that the intrahepatic approach had better control of tumor within the liver. You have basically, these studies are selecting for patients who have liver-only disease. And in terms of response rates or shrinkage of percentage of patients having shrinkage of tumor, we're seeing an improvement compared to the standard therapy. And in the curves that I've taught you to look at, they looked at progression-free survival, looking at the liver only versus the whole body, which would be progressive-free survival. And patients who received this IHP did better than the control group. It's still too early for this study to look at overall survival, and ultimately that's what the provincial payers are looking at. They want to identify patients who live longer because of this treatment, because if you administer the treatment, you reduce the number of progression events, but it doesn't help patients live longer. It's not clear that the cost and worry of the treatment is worth it. There was another study that compared these approaches, looking at Y90 versus TACE therapy. And in that particular study, Y90 therapy seemed to do better than TACE. Now, the problem with this particular study is that we don't have overall survival. It's only progression-free survival. We're identifying specific types of patients that are amenable to this approach. And then also the TACE procedure that was used in this study is different than what TACE procedures are used at other centers. So many folks in Canada will look at the group in Jefferson and Jefferson Hospital in Philadelphia, and they're not doing the same type of TACE there that is described in the study. So which of these therapy is best to use is still unknown, and further studies will need to be used. So the take-home points for uveal melanoma is that there's definitely a major unmet need. You may have seen interpreted from these curves that the survival rates are not very good for the non-tebentafos therapies. We definitely need further options for systemic therapy, and certainly that's being investigated. Because of these results with the intrahepatic liver perfusion, there may be pressure or a thought that, hey, could I get this administered and maybe go to the US for these therapies. It's a big deal. We're still not sure if overall survival is benefited, and to have it set up at your own institution in Canada is challenging because it requires operating room time. It requires an admission to the intensive care unit, and if we don't have long-term survival benefit, I think it's going to be challenging to make this a standard therapy. So I think more data is needed from development of these trials, and with further trials and follow-up from the current trials. And then also, hopefully, we'll have more systemic therapies become available for patients so that we can provide treatments that are effective. So with that, I'm happy to take further questions and help answer them.
Hey, Dr. Butler, I've got one on the screen. I don't know if you can see it. I experienced progression at stage 3 on adjuvant Pembro with BRAF mutation, switched to targeted therapy after developing bone and brain mets. Can Pembro be retried given the stats you showed earlier, or is Ipi-Nivo or Nivo-Rela the next standard of care?
So that's a really great question. So, and this also depends on where you live in terms of what the options are. So because some of the provinces have different rules in terms of next steps. In general, most of the provinces will have ipilimumab single agent funded as an option. The Rela-Nivo in this setting, there's very little data to help tell us what the best option would be, because there are very few patients that have been treated in this setting. I will say that in the phase 1, looking at relatlimab combined with nivolumab, and also other LAG-3 inhibiting antibodies, if you had prior anti-PD-1 therapy, the response rate was a lot lower with that combination, and it was in the range of 10%. So second line, Rela-Nivo, we're less enthusiastic about, but it's those studies were early phase studies, so We're not sure, but it does look as though it's better as a first-line therapy. For patients that have had prior anti-PD-1, there is a fair amount of data from the real world where patients receive combination ipilimumab plus nivolumab. And there's also some randomized data looking at this scenario. And the response rate looks like it's around 30%. So if I had to make a choice between Rela-Nivo or Ipi-Nivo in someone who has, well, right now I don't get to make the choice because I don't have it as an option. But if I did have it as an option, I would choose Ipi-Nivo as my treatment. Some provinces will fund more Ipi-Nivo in this setting. Some provinces won't. There are some clinical trials looking at this question. We just opened a study with Ipi-Nivo plus or minus an anti-IL-8 antibody. But in that study, there are some rules as to how the progression event was documented, and that you have to review patients' history to know whether eligibility is possible. And there was also some other studies looking at this question. So hopefully there will be options for patients. But it's it's a great question because we really don't know what the right therapies are for patients when they've had prior immunotherapy and targeted therapy. A lot of times we poo-poo ipilimumab, but as you know, Kathy, it can be a great drug for some patients. So not to miss out on that treatment, which definitely can help some patients.
Agreed. We've got one more question. Are any other new systemic therapies under investigation, trial in Canada for metastatic uveal melanoma? If yes, do any seem promising in extending OS and or PFS?
Yeah, so yes, there are excuse me, there is there are currently, we are accruing to a study with a drug that is a protein kinase C inhibitor. It's called IDE 196. It's showing exciting results, fair amount of challenges in terms of side effects, but we're dealing with that. But it's showing important and interesting results. Currently, we're looking for patients who are treatment naive for the slots that are available, but we don't have other slots available at this time. But there are trials like that, and then phase 1 also has trials that are sometimes appropriate for that setting.
You must be getting tired. I keep forgetting you're 3 hours ahead of us. So I just kind of want to end. Oh, wait a minute. We have one more question. Why did Tebi only work for 50% of the patients?
So that's a great question. So tebentafusp is and we didn't go through a lot of the details on how this drug works. Tebentafusp is able to recognize tumors in the context of a molecule called HLA. What that basically means is that tebentafusp is using the immune system to attract the immune cells to the tumor. And the particular mechanism is through a T cell receptor, which actually has to speak a specific language that is different in different people. And 50% or about 45% of patients in Canada have the right language, HLA-A2, and that's a requirement for tebentafusp to work. So unfortunately for patients who are not HLA-A2, we have to find other therapies.
Thank you, Dr. Butler. What can I say? You're amazing. I had 2 sheets of things I was hoping you'd cover, and you got them all. I want to go back to something you said, though, about the importance of the conversation and the dialogue and discussion with your oncologist. That's something that we really promote at Save Your Skin. Those are discussions you need to have with your treaters. I wonder if you can talk just for a second about the importance of clinical trials. On our Save Your Skin site, we have the CanadianCancerTrials.ca and clinicaltrial.gov, so that patients can actually get on there and see what's happening across Canada and in different centers. How do you feel about the clinical trials and the importance for patients?
Well, I think it's really very important for a couple of reasons. One is that it can often provide you with options that are verging on standard of care, but are not quite available in the particular jurisdictions. So sometimes it provides us with an option that if you lived in the US, doctors might use more easily. So that it has that selfish benefit for patients. It's not selfish, it's just it does have that benefit of providing options for folks. But more importantly, I think, is that the clinical trials will provide a way for us to understand whether a particular drug treatment is effective and useful for patients in the future. There have been studies that have looked at the quality of care within the clinical trial. There are a lot of safeguards to make sure that patients get optimal therapy and are not receiving treatment that would not be adequate or standard. So in some ways, it gives the same level of benefit as a standard of care, but it also may provide options that are becoming standard of care in the world, but are not quite standard of care locally. And then it also provides options that are future looking in terms of treatments. If I think that it's dangerous to just do clinical trials if the trial doesn't make sense, but having a conversation about the options is important.
Okay, so you and I have been around this space for a while. For me, I was diagnosed, in 2003 and started the foundation in 2006. I think you and I did a live symposium way back before 2011, and your presentation would have taken all of 5 minutes because there were no treatment options available for metastatic melanoma. Tonight, you've talked about metastatic, you've talked about adjuvant, acral, Merkel cell, basal, Merkel, oh my goodness, ocular, and all the new advances in this space. I know from a patient and from running the foundation how amazing innovation has become in our space. So as somebody who stuck with us for all this time, tell us what this means to you as a physician. From where we were prior to 11 and you actually coming into Canada to where we just are in this moment.
Yeah, I mean, I think that if you think if you think back to where we were, it's really just been 10, 15 years ago. Most of our patients would present and you would help them along with maybe give them some medication that helped them for a few months, but then their disease would progress. We had the rare patient who did well on a vaccine trial or on high dose IL-2, but it was a challenging type of therapy, and it wasn't the majority of patients. So now, I have patients who have started families that are living a normal life. I see them once a year. I'm a little afraid for my stage 4 patients to not continue to monitor them. I want to make sure that everything stays controlled, and under control. But we are getting to the stage where you're wondering whether it makes sense to do scans every year for those patients, because there's no evidence of progression. So it's been really exciting to be able to see this development and a change in practice, and so that's been really exciting. I think the other thing, though, is that expectations have changed. People didn't have high expectations 15 years ago when you had stage 4 disease. And now we're really upset when we lose a patient because it's just not supposed to happen that way anymore. So unfortunately, it does. I think there's a lot of more research that needs to happen, and we really need to address the fact that patients do develop resistant disease and figure out ways to help people beat this and live longer with good quality of life.
Well, thank you for everything you do. Hang in there with us. Our next post ASCO might have to be 2.5 hours. Who knows? Thanks again for sharing your time. I know how busy you are. We really appreciate it. Marianne, I'll let you close this up. And thank you, everybody, for attending.
Thank you.
Yeah, again, thank you so very much, Dr. Butler, for sharing your insights with us. I'm just so impressed with how your ability to make this information so digestible for lay people like me. So thanks again. And to all our attendees, thanks for attending today's webinar session. Again, I'll mention that this session is being recorded and will be available for viewing on the Save Your Skin Foundation website and our YouTube channel, as well as sent to all who registered. If you have additional questions, please send them to myself at marianne@saveyourskin.ca. So thank you so much for watching, and this ends the webinar session.
Thanks, Dr. Butler.
Thank you.